Moving on, we wanted to take the opportunity to really move into, in an applied fashion, some of the issues that we grapple with here in Southeast Michigan. And so it's my pleasure to introduce to you my two co-panelists, Najah Bazzy and Sheikh Ali Sulaiman Ali, and the three of us will be talking about a few cases. Before that, I just wanted to do sort of a brief introduction. None of us have any financial disclosures. These are mine as a physician, and so I just wanted to go through that. Before that, I did want to talk about, because of the success of the conference, I actually wanted to talk about some new organizations that we're going to be starting. I was thinking about starting the Shanawani Institute for Muslim Bioethics in America. Not to be outdone, Hasan wanted to start the Padella University for Muslim Bioethics University. We were really excited about this until we realized that these both spelled Simba and Pumbaa. This is a work in progress. I think those of us who are involved with end-of-life care, I'm primarily a clinician and a teacher of professionalism, and that's actually how I got into ethics and into Islamic ethics. And as an intensive care physician and dealing with the issues that Dr. Qazi brought up in his last question and some of these things, I have really a front row seat to this. And I've recognized that physicians really struggle with this. And to that end, in 2005, we had written some work on how physicians can meet the end-of-life care needs of our patients. And we developed a framework that was published that ultimately came out in 2008, and specifically looking at patient values and preferences, formulating their preferences and wishes into therapeutic goals, and trying to figure out whether I have the medical ability to actually meet those goals. And if not, we have to invoke futility. And the question that then comes up as a Muslim and as someone who recognizes that people of faith come to the hospital, what if the patient's goals are not medical goals that we can discuss in terms of medical terms and clinical outcomes, but rather existential and related to life after this one? And Dr. Arazullah talked about how, as Muslims, we believe that we have multiple lives, one before our birth into this world, one during this one, the one that we all experience today, empirically, of course, and then a life after the next. And to that end, I wanted to talk very briefly about cases. Najah, why don't I invite you to go first? She actually had a PowerPoint.
15 minutes?
Yeah. Go ahead.
So I have to orient myself to this stuff too. Good morning, everybody. Can you hear me okay? It's hard for me to hold still behind any podium. Okay, so 15 minutes. I'm going to try to take a chapter out of Sherman Jackson's presentation yesterday and speak so fast. So put your seatbelts on. Assalamu alaikum, peace and blessings be upon you. Just some of the things that I'm still dealing with in almost 35 years of nursing. And I'm going to have somebody who's, really good with this stuff stand real close to me. So some of the issues that are still important that I deal with on a daily basis, these aren't the hot fires, these are the daily fires: modesty, informed consent, persistent vegetative state, withdrawal, withhold, organ donation issues, autopsy, brain death, issues still around emancipated minors, generational communication issues, meaning that don't want mom or dad to know that they have cancer, therefore how do we treat? The issue with human remains in terms of skeletal limbs, amputated legs, what to do with them, some issues around Islam and burial of those remains, and then, of course, the whole advanced directives Islamic will. I'm going to jump right into a very critical presentation. I want to tell you something, dear audience. I know so many of you are clinicians. I do have a passion for ethics. When I present this case, it may feel like there's a bias here. There is. The bias is that I come from a very major patient advocacy perspective. So in your mind, you may be negotiating, is she for real about some of these issues? But if you can step into my clinical domain of patient advocacy, then maybe you can understand why this case was such a very difficult case. And Dr. Howard Brody actually helped me to write this case up to some degree with Gail Daly. So this case has been published. It needs to be published in more depth, of course, but here we go. So this was a 35-year-old man. I'm going to just run through the clinical perspective real quickly with the history of hypertension, presented to the ER with confusion, syncope. There was a massive intracranial bleed. Basal ganglia was involved, some arachnoid hemorrhage, cerebral edema. There was a lag time that became a case in the city because the lag time for the ambulance to actually get to the house was almost 40 minutes. The extended family of this gentleman had been killed in the Iraq War, so he had no siblings to help speak on his behalf. He was a father of 6 children, infants to early teens, and after this incident, when he arrived to the ER, the wife went into like a catatonic shock and was unable to speak, so we couldn't communicate with her. The cerebral herniation progressed. There was damage to the brainstem, and then severe hypotension set in with use of vasopressors that we tried to correct things, could not. You can see the rest of this, and ultimately what we're moving to is a medical management of a person who's progressing very quickly to brain death. So I'm not going to go through that. We established clinical brain death, but the patient was still a full code. So the patient was still a full code, even though the pronouncement of brain death had been made and entered into the chart. And here goes the yo-yo. So from a family view, these are the things, and I'm talking to you within a 3-week span, but the family views on the case was that for them, death is a cessation of heart and breath, that the brain was dead, but he was still alive because we often use this language of brain dead instead of dead. And so when physicians or clinicians are walking in and saying, I'm so sorry, your loved one has suffered brain death, to the layperson that means their brain is dead and they're still alive. And I think that's something that we really have to be very, very careful with. Our language has a lot to do with how it is we recognize and move forward through these things. The soul is still present according to the family due to the fact that he has a beating heart. They felt that the physicians were stepping on very sacred space, basically playing God. And so the family, whichever extended family they were left, which were cousins and so on and so forth, called upon community to support them, and also tried to go to the court system, realizing that brain death in Michigan was death, so they would have no support. The medical staff, on the other hand, was confusing the family with language, what I call the yo-yo syndrome. Brain dead is death in the state of Michigan, as we well know, but we're still arguing over this code status. I have to tell you, maybe some of you, especially those of you who are physicians, know that, especially in residency, I'm still scratching my scarf trying to figure out how it is that we talk about brain death and still walk into a family consult and ask about a code status. How do we do that? And why do we do that? And in what, with what type of compassion, I wonder, do we do that? And where does that come from? Is it lack of information and communication with the residents or whoever may be walking into the situation? Is it that there isn't enough mentoring on communication? How do you communicate sad news? And so this is a whole presentation that I can spend hours talking about. But also the medical staff was standing in judgment of the family because, of course, the family did not want to pull the vent and could not pull the vent. And the nursing staff especially kept talking about this terrible suffering of this man. The Sunni doctor that was a friend to the Shia doctor on this case was offering to relieve the Shia doctor who happened to have the same belief system that the patient themselves had had. The Shia doctor who was in charge of this patient was actually inadmittedly saying that he was afraid for his own soul, that there wasn't enough discussion around this issue, that he would feel comfortable enough signing off on the case and relinquishing this patient to another physician who felt very comfortable taking this gentleman off of the ventilator. Ethics wanted the transcultural nurse, which was me, removed from the case. And the reason that they wanted me removed from the case was because by week 1, I was advocating this patient's right to die the way the patient wanted to die, irregardless of whether or not brain death was death. And so I began to feel like just as we're able to help wean people off the ventilator who don't want to be on it, was there an opportunity to keep a person on a ventilator whose belief system supported that a ventilator is also a gift of God because it's a gift of the intellect, which therefore makes it something that's not such a bad thing. When we began to delve into the religious scholarly view and try to find a fatwa for what to do so everyone can sort of kind of be off the hook, this is what came out of this particular gentleman's scholarly appointment. In other words, the person to whom the great scholar that he was seeking his fatwa from, we were seeking on his behalf. This particular scholar, who many of you may have heard his name before, Ayatollah Sayyid Ali Sistani, who resides in Iraq, says that life is viewed from a social construct, and this is how he was getting his deductive fatwa. That when you ask the layperson what constitutes life and what constitutes death, the layperson would say a beating heart and breath. When asked about where the soul is, he responded by saying, the knowledge of the soul is with God, and that is what we are instructed by the Holy Quran, that we really don't know much about the dynamic of this eternal soul. He asked us, will the heart eventually stop beating even on the ventilator? And the answer was yes. He asked then, would you bury a man who is breathing with a beating heartbeat? And the answer was no. He then explained in his correspondence to us that in his deductive fatwa reasoning, understanding of the social construct and within the spiritual realm that he practiced, that quantity of life is quality of life because the soul can be in a state of atonement, in a state of unawareness, and in a state of a continued journey. And far be it from the medical staff to end that journey prematurely, irregardless of the physical function of the brain. He then said, how do you know that you are not pushing this soul to a worse suffering and a worse fate? And then reminded us that only God could decree the moment of transition. And then here was the scariest part. For the staff or the family to make the decision to remove the ventilator would equate to murder. Now, this is one Shia scholar's opinion, and on the opposite end of the spectrum, there is another Shia scholar in Lebanon, very famous, who just recently passed away, who says completely the opposite, that when there is brain death, you must remove the ventilator immediately and proceed with funeral procedures. However, when you're kind of caught in this, what it really comes down to is not so much which scholar, rather the patient's wish. And what did the patient advocate for himself very verbally in his lifetime? And that was a position that I was coming from. I know that I'm not going to be able to do this, so I'm just going to run through as fast as I can. Shireen, this is really hard, isn't it, 20 minutes? The suggested intervention. I suggested that we move toward very highly skilled communication, that we establish trust with this family because trust had been broken, that we show the family visual scans of the perfusion scan and let them see visually and physically that there was apparent definite brain death, that we begin to stop using the brain dead language and begin to use the language of your loved one has died. And not necessarily with this family, because we really weren't there with this particular family, but that moving forward, that would become important. And that we wouldn't add to the burden of the family by asking about code status and the removal of the vent. In my line of work in transcultural nursing, what you learn to do is a paradigm and a model that focuses on 3 principles: accommodate, negotiate, and repattern. I carry these principles in my heart, in my mind, in my psyche, in my clinical practice. They're part of how I do business in the world of ethics, and I think they're such valuable tools for everyone to have, whether you're practicing clinically or whether you're even at home with your children. These principles work: accommodate, negotiate, repattern. I was looking for the transformation, how we could move from a very difficult case that was a PR nightmare in the community as well, to a place where we could still keep this family somewhat whole and somewhat not so burdened with not only the loss of this gentleman and these children who were losing their father, but try to keep intact this wife and just so much of the dynamic that was going on. So I pushed, even though I was removed from the case, to accommodate the patient's right to die according to his belief system. I negotiated that we could move the patient to a room on a hospice unit that was not being used. We repatterned the family so that they themselves cared for the patient because the staff absolutely refused not to. And we engaged the community members to participate in the care as well. So now we're moving to the healthy part of picking up the pieces, so to speak. In terms of transformation of the staff in hospital, we used accommodate, negotiate, and repattern in these ways. We accommodated the physician by allowing him to stay on the case and not have to be burdened with pulling the vent. We negotiated to leave, though, the vent settings as they were, not to dial up and not to dial down. We repatterned the perception of the staff through educational opportunities, many of which turned into very, very thought-provoking in-services. We repatterned the dialogue in ethics, meaning our ethics committee, to include a broader understanding of patient advocacy and what does that really mean, and a different perception of what suffering could mean to different people in different cultures and different subsections of the population, and what ultimately death may mean from person to person, not just culture to culture and not faith to faith, but really at a deeply personal level. To do good and to do no harm? And I ask this question, according to whom? According to whom? Because what may be suffering for one person may not be suffering for another person. And then we revised hospital policy on brain death. So I moved to this concept of absolve and resolve. I have to tell you that the concept of absolving, which is something I feel I have introduced into the language, has been misused. And I am somewhat frustrated by the fact that the way it was presented and the way it's now being used are not congruent with the way it was meant to be. I say absolve the family when necessary and when needed, when they cannot make the decision or they don't have the medical capacity within which to make that decision. And you know, we call this world of paternalism as though it's something really terrible, and no longer can we just call it paternalism because it's maternalism and paternalism. But the fact that sometimes physicians can't place themselves in a position of authority that actually can absolve the family from the burden and from the residual guilt that could be associated with having to make those difficult decisions. The concept of absolving and absolving to resolve an issue is very, very powerful when seen in practice and when communicated the right way. Forgiveness, we've learned in the literature as well. The ability for the family to forgive themselves for not being able to save that life, or the physician to forgive him or herself for not being able to perhaps mitigate or bring about something that was more peaceful. We want to resolve the conflict by seeking other options. And here is a 10-10-10 rule. This is an old stat, but I think it's so powerful. And this is one of the paradigms I was working from for this particular institution. This is a stat that came out in the early 2000s, so it is aging, but it was that it takes $10,000 to attract a customer to a healthcare system, 10 seconds of negative interaction to lose the customer or client, and 10 years for the memory of bad service to go away. Test it. It works. And so we did not want this institution to be in a position where the memories of what they would consider bad service would linger in a community that would definitely know about this particular case. In the end, memories are the only thing that our patients and families have left when they do leave our institutions. And so I often ask myself, what memories do we wish to create and share with our patients and our families? I'm a very strong believer of ushering out death with dignity, however that dignity may be realized, and to really work toward that aim. So that case in particular, and there are so many. I mean, I have case after case, everything from infants in utero all the way up to, the end-of-life issues, and hopefully we can talk about them more in detail. Did I stay to 20 minutes? Tried. Thank you all so very much.
So I was remiss in introducing Ms. Bazzy, by the way, she's a transcultural nurse specialist, as she said, and she has 25 years in working with patients. And she's now the CEO of Diversity Specialists in Transcultural Healthcare Solutions and the executive director and founder of Zaman International, which is a humanitarian not-for-profit organization that provides services here in the Metro Detroit area through Beit Zahra, refugee resettlement, educational and vocational training for women, mobile food pantries, and infant burial as a variety of organizations. And she's been known throughout Michigan and through most of the medical centers for her work on this subject and others, including interfaith dialogue, gender equity, inequality, human rights, and medical ethics. It's my pleasure now to introduce Imam Ali, who's the co-founder of the American Learning Institutes for Muslims, ALEM, which is he's a primary instructor of its programs and a member of its board of trustees. And he's the full-time Imam for the Muslim community of the western suburbs here in Canton, Michigan. He came from Accra, the capital city of Ghana, where he studied Arabic sciences, Tawheed, Fiqh, Dhiyat, which is asceticism, and the Sirah, the history of the Prophet, on his name be peace. And after years with his teachers, he completed his curriculum and moved to Saudi, where he studied at Medina's Islamic University, where he completed his studies in 1979 in Islamic studies. He also has a master's and PhD from Islamic studies here from the University of Michigan. And he completed his dissertation in Tafsir bil-Ma'thur, specifically dealing with the question of hujjah, which is the question of authority or binding proof. And as a teacher, he's taught Islamic studies at a variety of universities, and he's worked as a professor of Muslim world studies and of Arabic, and he served a number of communities. Please join me in welcoming Imam Ali. Whatever you prefer.
Assalamu alaikum, peace be upon you. The Imam of the Muslim community is expected to have answers for spiritual, social, economic, and even political challenges and needs of the community. If the Imam failed to meet these challenges, then he's fired. One of the difficult challenges facing imams in USA, I say one of the difficult challenges facing imams in the USA is bioethical issues. This is a particular concern when someone has a terminal illness. I'm going to talk to you, brothers and sisters, about those cases in which I have been personally involved. I don't know if these cases will benefit you in one way or another. I'm not sure. But this is what I was asked to do by my friend, Dr. Asim and Dr. Hasan. I divided those cases into 5 categories and will elaborate on some of them. Funeral preparation, number 1. Life support, transporting the disease, the disease to the country of origin, organ donation, and number 5 is will. I'm just going to talk about the cases. One of the cases that I got involved with was a case of a man who had a terminal ill. I used to visit him at the university, at his hospital, 2 days before he passed away, I was there and found him and his wife getting into theological debates. It was very heated debate. He doesn't want to be kept on life support. And his wife wanted him to be kept on life support. So he asked his wife, do you think this and a life support will prolong my life? As Allah has already decreed, I have a time. When your time comes, you go. And the wife said also to him, do you think that whether we keep you on this life support or not, when your time comes, you won't go? So the man said, this is, for me, I really don't want to be kept on the machine, this machine. So this is a very difficult situation for me. They are expecting to hear from me. And I have to consider this situation, the will of the man, and what the family also is going. I have to consider the family also. I'm not going to tell you what my advice was. Yesterday I learned a good sunnah from my brother Musa. We lay everything, inshallah, in this evening. I think there is a lot of discussions that's going on. And this is one of the issues I believe that they are going to discuss. One of the cases also, I found myself helpless. And I was hurt. And until today, when I remember the case, I feel very, very, very bad about it. This is the man who was dying at the hospital. He married to a woman who is not a Muslim. Then he asked the wife to call me to come and visit him and pray for him in the hospital. Before I get to the hospital, the man has gone. He's gone. So the wife said, Imam, you can pray for him. And he asked me to tell you to wash his body. You can pray for him, but I'm going to cremate him. We beg you, please don't do so. He's a Muslim. He has to be buried as a Muslim. She said, no, I'm not going to bury him. I'm going to cremate him. We told her that we will pay for the funeral and everything. She said the issue is not a matter of money, but that is what I want. And we asked her whether or not he left behind a will. She said no, he didn't leave any will. Anyway, I found myself helpless in this situation, and she cremated him. Similar situation. We were called in Sterling Heights, me and another Imam. A young man whose parents came from Eastern Europe for a long time. The mother died. When the mother died, they cremated her. So now the father died now. He asked us to wash him and pray for the father. But he wants to cremate the father, to bury him beside her mother. We told him, please, this is a Muslim, and we have to bury him according to Islam. He said, well, they are Muslims, I'm not. He said, listen, Imams, when I die, dump me in the garbage. This body is not here. I want to cremate my father. You want to pray? Fine. You don't want to? You can go. Helpless situation. It's a very painful situation. The third case that I'm going to relate to you, was a case of a man who came from a state. He came from a state, let me say the state, New Jersey, to Michigan here for looking a job. Unfortunately, he got cancer. All his family and relatives were in New Jersey. So the cancer spread rapidly, and the doctors gave him a few days. He told us that he wants to be buried in New Jersey with his families. And the doctor, we consulted his doctor. The doctor said, this man cannot travel. We want to take him by plane. I don't know if we make a good decision or not, but that's what he wants. He doesn't want to die in Michigan. We were able to raise about $7,000, $8,000 to put him in a plane. But the doctor said, no, he can't travel in a plane. We can transport him in a van with the medical equipment. We have to research someone with him. We told him that your family, you leave behind helpless children. Let's just take this money, maybe to give it to the kids and all this, to bury you here and all these things. He said no. He doesn't want to. He wants to be buried there in New Jersey. So what we'll do in this case? Well, we bow to his wishes, and we send him with some people to New Jersey. When he arrived the next day, the man passed away. So we have a lot of challenges that facing imams. I know that we have some imams here, and every imam might have a unique, distinctive challenge. One of the challenges, it's not a challenge, one of the things that, and the cases that we involve, and when someone is dying, has a terminal illness, call imams, discuss with him about funeral preparation, and in May particular, this person asked me which funeral he should be taken to, where he should be buried. He should be buried close to the masjid. That means talking about the Diaba Mosque, whether he should be buried in his local graveyard, and so on. Because he believes that close to the masjid maybe will get him some blessings and all these things. We explained to him that it's better to be buried in his local and the graveyard, so that it will be easier for his people to visit him, and so on and so on and so on. So, brothers and sisters, on the issue of bioethical and Islam is a matter of, I don't want to get into that because that is not my speech. We have scholars who are going to discuss this issue. But the first example is that the case I gave it to you, husband and wife, when they get into theological issue, that's the core of everything. Divine decree, or the reality of Islam and reality of technology. That is the two things. In all the discussion that Sheikh is going to discuss with you today, and Sheikh Musa and the others, is about the reality of religion, Islam, and reality of technology. So I hope these short stories that cases that are presented before you will benefit some of you. I don't know if this is the kind of the story you want to hear, but this is what I would like to present to you. And I'm telling my Muslim brothers and sisters to have your will written before you die. And this is something that it is good. It's a principle in Islam. And our Prophet Muhammad told us, don't go to bed without writing down your will. If we have a will, we don't have all this kind of problem. Thank you.
Before we start the panel discussion, actually I need people to not be in violation of the fire code. So I need you all to please find seats. Otherwise, we're going to be stopping the program.
Yes, sir. So what we would like to do is we've got a lot of great people in the audience, scholars of religion, ethicists, clinicians, people. I wanted to open up the case while you guys are gathering back into the seats, and I do appreciate that. Let me share with you maybe one more case just to give it some time. I think Sheikh Ali has talked about the role of the Imam, and Sister Najah has talked about the role of patient advocates in the intersection between the patient, the family, society, and the hospital. I'm an intensivist, and so a lot of these cases end up under my care, and I've dealt with a number of cases like this. One of them I dealt actually as an ethics consult, where they called me in because I was the Muslim doctor. And so therefore I'm an expert on all things Islam and medicine, and this family, and it was one of these sort of what I call talk some sense into the family consults. And it was a patient with widely metastatic lung cancer, cancer that had spread throughout his body to his brain, his bones, his liver. His liver was shutting down, his kidneys were shutting down, and it was clear to all of us who knew the case and had a decent understanding of medicine that his time, and God knows best, of course, was going to be measured in minutes or hours, not days or weeks. But the family, the patient himself, who was becoming delirious, some of his last words were, "I need to be full code, I need to be full code, I need to be full code. Please don't stop the therapies." And the family, he had a son and a wife who were, in particular, they were supporting this. And they came to me, and, you know, Brother Hasan, they knew me from the community, you know, help us out here. We can never say that we should be anything but full code. We can't face our Lord. We understand what they're saying. And they said to me, actually what Imam Qazwini had said yesterday, every hour, every minute, every second is sacred to us. If the doctors don't want to offer us therapies, or if they don't think that therapies would work, it's on them. I saw a door that was opened to me, and I walked through it, and I remembered one of my mentors, Jose Ortiz, who was a cardiologist and a very devout Catholic, who said to me, only half-jokingly, "You know, Hasan, we folks that take care of dying patients, there's a long line of these people waiting for us on the last day. And you better be ready to answer every single one of them." And I looked at this and I said, is this a case where I would be willing to accept responsibility as a Muslim for making this decision and taking the burden off the family? And I stepped very far out of my role as an ethicist and as a clinician, and I said to this family, now speaking to them as a brother in faith, you know, I'm going to tell the doctors to not do it. And I will face God on this for you because I think it's the right thing to do. And when I said this to the patient's family, they said the relief was just absolutely visible on their face. That this existential question to them, we cannot face God, we cannot make this decision. And I sort of embraced my white coat and said, you know, I'm going to make this decision for you. But it was a decision that I was taking with ramifications that had nothing to do, I think, with clinical medicine. And I think most physicians in the audience, and I would welcome your comments, would agree. Likewise, there was another case that I took care of. As a lung doctor as well, I take care of a lot of patients with lung cancer. An acquaintance who I saw clearly only had about a year to live, and was debating whether he should actually go on Hajj, which is a once-in-a-lifetime requirement of Muslims, for those of you that are unfamiliar with it. And this man had never completed this requirement. And he said, he was debating whether he should go on the pilgrimage to the holy city of Mecca and follow the ritual pilgrimage, or if he should go into an experimental chemotherapeutic regimen. And he said, you know, I may live longer if I do this regimen. And I looked at the regimen and I knew the data on it, and I said, go to Hajj. I said, it's not going to work. And again, I'm not an oncologist, but I knew enough about the data to say, I got to be honest with you. And I think if you don't go this year, you're not going to get another chance. Sure enough, his disease progressed and he was never able to go to Hajj. And in his last days, he was a pillar in the community and was working on work for the community that I won't reveal because I think it would enlighten you as to who the person is and for the sake of his privacy. But suffice to say, in the days before his death, he was furiously working on this important work that he was doing for the community. And he was terrified that if he died before the work was done, that it would die with him. And again, I sort of reached a little bit outside of my realm of comfort, and I said to him, you know, and he was, and this man, his iman towers over mine, his faith in God and the unseen towers over mine, but he was scared, and I think he was really lost at this moment. And I, as Islam says, the good friend is the one who, when you do good, praises you, and when you fall short, reminds you. And I reminded him, I said, you know, you've tied your camel. Now have faith in God. And I think you should spend, and I looked at him and I really felt that he only had 2 days left or 3 days left. And I said to him at this point in time, I can throw, there's no limit to the technology I can throw on you. It's not going to make a difference. You have a few moments left in this world. And I think that there are things that our deen calls upon us to do in the last few moments of life. Remembering God, remembering the oneness of God, remembering our role as creation, seeking forgiveness from Him and those around us, settling our debts. There are rituals and aspects, and I said, the time to do these things is now for you. He listened and followed these things and died within the next 48 hours. And I received a lot of gratitude from the family. Again, as a clinician, I felt a little uncomfortable. I really felt that I had reached out of my comfort zone, but I felt somewhat of an obligation with both of these cases to advise them in a sense that, truth be told, I have no training in. And only out of a vague sense of shared faith did I say to myself, I'm going to take this chance. At the end of the day, I feel like there is some expertise that I own, and that is of clinical medicine. And in Islam, we believe that when the expert is called upon a question, when he answers it, if he answers it correctly, he receives 2 benefits from his Lord. And if he answers it incorrectly, he receives only 1. But he still receives a benefit. And the person who answers a question outside of his expertise, if he answers it incorrectly, receives 2 sort of demerits from his Lord. And if he answers it correctly, receives 1 demerit. And so this is one of those, so I'm very loosely translating the statement, and in the presence of the scholars, please forgive me for that. But I said to myself, I find myself asking the question, what exactly am I an expert in here? And what am I not an expert in? And that's what started me on the journey that ultimately led to Dar al-Qasim, and Dr. Al-Razallah talked about this yesterday, and I really needed to, I think, bone up on a particular aspect of my knowledge. But you're all in your seats, so let's open it up. What are your thoughts about some of these cases?
So before we open up, we're going to pass the mics around. So I'm here and Shamal's over there. We have about 40 minutes, so try to keep your questions very brief and focused. And with that, we'll open it up.
And we are recording, so please be sure to use the microphone so that we can get your question.
I want to thank you for an excellent presentation. For Sister Najah, I need you to clarify for me, according to the dictates that you outlined of Ayatollah Sistani, in that particular case with a brain death patient, should CPR not be offered in order to allow for continuation of that transition period, or are you suggesting CPR should be withheld? If you can clarify that for me, I'd appreciate it.
After the declaration of brain death, and there was the discussion of a code status, many of us kind of lost it and said, what are we discussing a code status and a person who's pronounced dead? And so we did not offer that. We did not offer that up. We did not write to Sayyidi Sistani and ask him if his heart stops, should we resuscitate the heart? Because that was not something that the staff was going to do anyway. The real issue was the vent and the removal of that vent. So the question did not come up.
Would you provide pressors? Would you provide antibiotics in that situation?
So what we did was, in that negotiating piece, everything was taken off except for the vent. Because it was actually the vent that would be the causative. If you turn the vent down, there is no more breath, no more heartbeat. So the pressors were removed from that particular person, and he was in a maintenance state. His case lasted 3 weeks. He actually did survive full 3 weeks, And there were a lot of other questions that began to really almost haunt many of us on both ends of the spectrum. The fact that his body was decaying, and the dignity around his actual body, and the ability as staff to try to remove ourselves out of the importance of the physical and try to move into the spiritual realm of this patient. So that was very challenging for us, but Sayyidi Sistani was very, very clear about what needed to happen for this patient. Thank you.
We're deferring the manager. Dr.
I have the other mic. Jim Rustoven from Hamilton, Ontario. I'm a medical oncologist, as you know, and I want to thank you for your narrative of your own experience. It's one that we go through for a living. It never gets any easier, but we hope that we gain some wisdom in the experience that we have from others. I'm here in part to understand better the Islamic tradition as it applies to medicine, because my PhD work is looking at a covenantal ethic as an alternative to principles-based ethics. So I would encourage continuing to share these cases for both of you, all three of you, for those of us who are, as it were, in the trenches, but also for those of us who want to better help our trainees to understand how to be not just more empathic, but to be truly global in our understanding of relationships within medical practice. And that includes families and the traditions that go along with them. I don't know if there's any way, but the covenantal ethic, as you all know, is one that speaks to all three Abrahamic traditions, because my understanding of covenant goes back to creation, not to the people of Israel. So I think looking at that as maybe a theme, I would encourage considering down the road a conference or even a larger forum through which people who are in medical practice, particularly those dealing with end-of-life issues and cancer, get together and share these experiences, because there is so much resonating that goes on just with sharing the nitty-gritty of the understanding. But I think it can go much deeper than that, theologically and otherwise, for mutual sharing and understanding in that respect. So thank you very much, the three of you.
So thank you so much for this panel. I wanted to address Dr. Hasan and my sister in faith and in everything else, Najah, because I saw you struggling with what I think is an impoverished language that we have in bioethics that pits patient choice and autonomy against paternalism and coercion and all of those things. And what I see you trying to do is find a middle ground whereby we can appreciate the huge amount of burden that choice, can place on a family. And so I just wanted to suggest a little bit of something that I've read and I found very useful. And this is a Dutch philosopher and MD named Anne-Marie Mol. And what she has a small book now called The Logic of Choice. No, sorry. It's called The Logic of Care. And the point of the book is to say we've gotten ourselves into a very difficult corner that now we have to get out, because we've put a priority on choice and disregarded all of this evidence that shows that when people are really vulnerable and in these moments, that if choice is all you're leaving the patient with, it ends a conversation instead of beginning. And so what would it look like if we change that language to a logic of care instead of choice? And we're always moving back and forth. And so I think that was just at least helpful for me to get outside of some of the linguistic obstacles in talking about how you can empower people through relieving them of burdens that making them be fully responsible for decisions that are really exacerbating the suffering that they're already going through. And to Sheikh Ali, I wanted to say in the cases about cremation, where one spouse wants cremation, what I also found helpful was, and this comes from, why am I blanking? Sayyid Hussein Nasr, who does a lot of interfaith dialogue. And one of the things that he does, which I think is very useful in trying to transcend these divisions about burial practices versus cremation versus what, is by showing that if one looks anthropologically, you can find that peoples where water is primary, like in Oceania, old Oceania customs, will put their dead in water because water plays such an important symbolic role in that society. And people in like the moisture heavy places of South Asia, etc., turn to fire. And these are all elements of God's creation, whether you use fire. The Zoroastrians are the only people who use the element of air by putting their dead on the mountains and using their. So what I mean is if you get outside the discourse of what is the most dignified way and just point to water, wind, fire, and earth as all elements of God's creation, then for Muslims it happens to be earth that we put the primary on, then maybe that can open a better dialogue for, so that you're not resorting to language of whose is better or who gives a better passageway to the afterlife.
Shireen, I think there's a lot to be said about compassionate conversation and communication and the way in which that happens at a very skilled level. And that's an area that I think we need to teach and train our medical staff in. There's a way to do that.
Dr. Taib from Shelby Township. Question regarding the difficulties of taking away life support. In the context of poorer societies such as India, where I come from, people make daily decisions to not be very aggressive when the end of life is near. And that also is a practical or a fact on the ground that changes your ethics. How does that work in this context here and out in the context of very limited resources? Also, I think as a practicing Muslim, at least I believe, I'm not a scholar, that when the time comes, it's better to gracefully accept death and prepare rather than fight it. So I don't know what the Sunni and Shia perspective is on that.
I would like to make a comment on that, Sister. It is true that the people have a different opinion in terms of which is the best dignified way to bury their deceased. Okay, as a Muslim, our way is to bury the body, not to cremate the body. So the Muslim would like to be buried as a Muslim. Muslims would like to bury as a Muslim. So we cannot cremate a Muslim.
So, Doctor, I just want to verify. I want to clarify something. I don't think these are issues of Sunni or Shiite. I think they're issues of a person's free will, their decision, and the level, how it is they attain their decisions from a scholarly level. So, because I think on both ends of within the Sunni Shia spectrum, there are multitudes of opinions. Either way, in the Shia spectrum, there's completely opposite opposing. And I think often in the Sunni community, while it seems to be a little bit easier to arrive there, I still think that there's a deep emotional struggle that happens with patients and families. So the issue of resource allocation, obviously in Islam, and Sheikh Musa can speak better to it, Islam is very much concerned with limited resources. It's not that there's an abundance of resources and we're allowed to waste. We are not allowed to waste. However, often people say, well, if they were back home, they wouldn't even have that option. But that's not the reality of the discussion. The reality of the discussion is they're not back home, and they are here, and the resource is here, and there isn't another person who's needing the vent. In other words, the allocation is kind of something that we talk about out there, but it's not right there in your hand. And I often wonder, so if there was only one ventilator and this 35-year-old gentleman was on that ventilator and declared brain dead, and there was a child who needed that vent, would that have changed the scenario? Most likely, yes. But we have to deal with the reality at hand when we're clinically dealing with these issues. And so, but oftentimes people say, well, if they were back home, they wouldn't have had that decision to make.
And if I could add to that, Chikaku, I think that the question that you ask is precisely the reason that we're trying to have this conference, because the bioethical imperative is very different here in the United States than it is perhaps in a developing nation. We have different resources, we have different things, and so, you know, God does not ask of the person, does not bear upon the person a burden more than he can bear. Well, the burden's a little different here for us than I think it is for other places. If you don't have those resources. And I think the other thing that we have to do as clinicians is we have to say, clinically, there may be some pretty important differences. I mean, if you stop breathing in a developing nation and it takes you 3 or 4 hours to get you to the hospital, and you're still doing well physiologically, your kidney function, your hearts and everything, you're a pretty healthy guy, right? Because you probably didn't get much care in terms of, or much life support in those intervening 2 or 3 hours between when your breathing failed. And here, on the other hand, we are going to throw the world at you. So if your body is doing badly after we've offered vasoactive, CPR, intubation, antibiotics, fluid resuscitation, defibrillation, cardioversion, pacemakers, and your body is still doing badly, you're dying. I mean, your body is really failing. And I think there's actually some important clinical differences as well as bioethical differences that we have to put together. And I'm not suggesting that the two are separate from one another, but if we break them down into these different elements, I think there are different questions, which is why we've really wanted to push for really a bioethics conversation about faith and bioethics in Islam that really comes out of the United States, because we just deal with different issues, I think, as physicians and as patients.
What about the question of accepting death easier rather than trying to?
I'm not convinced that technology makes accepting death any easier. I think it makes it a little harder because it's the kid in the candy store problem.
But in those situations where the case Najah described, looks like extremely futile, prolonged and more of what we would say is suffering.
Right, right. And actually, I often wonder in this particular case, and there were 3 cases that followed right after that, I often wonder if we did not, and this is a moral dilemma for me, inside of my heart, if we did not use the language brain dead, and we went in and we said, your loved one has died, we are moving to the removal, we are proceeding to the removal of the ventilator, where and how, and this is for the roundtable discussion, I have all of these questions about, does Islam have a concept of futility? And where is the soul? And how does this interact? And all of these different types of questions that this conference is going to be so helpful to help many of us work through. I do have to say, in defense of the family and their belief system, they weren't fighting death. I've never really, in 35 years of doing end-of-life care, I've rarely seen anyone fight death. But rather, there seems to be something going on that's not quite explainable in medical terms, that has its own world, and that there are things going on. And lastly, what I kept hearing is, this person has no quality of life. And I was sharing this with Dr. Muzammil Ahmed. And I now say to myself, if he had no quality of life, why are we still talking about him? And is his legacy in that particular case?
Assalamu alaikum. My name is Zahir Sahlul. I'm a critical care specialist from Chicago. And thank you very much for putting this conference. I hope that you can also put similar conference in Chicago, because there is large Muslim community there and physicians also who need to be educated about this issue. I'll be helpful actually if you'd like to do that. And sorry to miss the first day. I have 3 observations coming from my practice in critical care medicine, dealing with end-of-life issues and also being active in the Muslim community. The first one, that Muslims, probably similar to other minorities, have sometimes lack of trust in the system, and this is very similar in particular to the African American community. And I noticed also that there is a lot of similarities with Jehovah's Witness and Orthodox Jews in terms of looking at the end-of-life issues and making sure that the patient, their patient, will be alive until the end, in general, in the community where I'm dealing with. and maybe these issues need to be addressed. The other issue with the Muslim community in general, that there are not much education about end-of-life issues, and this is responsibilities on our imams and scholars and also Islamic centers. I think they should have venues for education. The second observation about Muslim physicians who are dealing with end-of-life issues, they're not very comfortable and probably educated about end-of-life issues from Islamic perspective. I think these conferences would be helpful so we can be more confident when we speak with Muslim families about end-of-life issues. One of the tradition which I was aware and I was not aware of about Prophet Muhammad when he was dying, that he refused to receive medication, and he said, do not force me to take medication if I don't want it. And also there's a tradition about Prophet Muhammad saying that there are a group of people who may refuse treatment even though that they know that they're dying. And I think conveying that message to patients who are who want to be comforted with stories from the Prophet, that will help making them reaching more comfortable decision about end of life. The third observation is about our imams. With all respect to them, in our imam, the imam which we deal with in our community, he usually defers to the physician when discussion with end-of-life issues. Not to undermine the importance of the imam, but I think we have to defer to the expert, and the expert here are the physicians who are dealing with these issues on a daily basis. With all respect to Imam Sistani and Imam Qaradawi, life has changed now from 2 centuries or 3 centuries ago. You don't have a level of expertise with our scholars that is needed in dealing with these issues, and I think they have to defer to physicians who have Islamic background and who are versed in bioethical issues than to comment about issues who they do not know probably.
Thanks for your remarks. I agree with a lot of them. I should point out with that first case that I was talking about where I was called in as an ethics consult, there was no doubt in my mind when I spoke to this patient and his family that they knew everything. They knew very intimately exactly what they were saying yes and no to. They knew all of the clinical technologies. They knew about dialysis. They started talking to me about the different modalities of dialysis. Should we start offering CVVH, CRRT? What kind of ventilatory modes are you going to use? I mean, this was a very literate family. And so I think a lot of times we think as clinicians, if we just talk some sense, if we just explain to them, if we just sat with Imam Sistani and explained to him, what we knew, he would change his mind. There may be some data that supports that. In fact, there was a study that was published about brain death where they sampled a number of religious scholars. And I agree with you totally that we own the knowledge of medicine. But I also think that if we claim to own the knowledge of medicine, that we have to be deferential ourselves, especially when it comes to the knowledge of deen and ahkam. And I think this is where I get a little anxious. And I think when I start quoting a hadith to a patient, trying to justify a particular clinical course, I'm reaching way out of my comfort zone. And I would no sooner ask Imam Sheikh Amin for advice on, say, oncologic courses of therapy, although you may very well have an opinion, a particular one oncologic course of therapy. I don't think that you would put much credit yourself into it. And I think, likewise, I would not expect Sheikh Amin or Sheikh Musa or Dr. Sajidina to ask me very much about principles of Islamic ethics or ahkam or anything like that. I think there are clearly places where I am the expert and the teacher, and there are clearly places where I believe I'm the student. And so how do we build that relationship? And that's what we talked a lot about yesterday and a little bit more, God willing, this afternoon.
I have to add something taken from the page of Sheikh Musa yesterday. I have to run to the defense of the scholar. One of the things that bioethics has taught me is tremendous humility about areas that I may not know, about deductive reasoning that I may not understand, about constructs and contexts from which I may, in my medical mind, not understand another perspective. I have to tell you that I thought that Sayyidi Sistani himself sits in kind of this almost cave-like area, unattuned to the world around him, making these fatwas without information. And I stand very humbly wrong, because he is at least from the understanding that I have, very credible understanding, that most of the scholars in Islam, the most highest level of scholarship, are not making decisions in a vacuum, but that they are actually sitting with experts, and in this particular case, neurologists and neurosurgeons. But just because the outcome might not be something that Najah Bazzy is comfortable with, and I was uncomfortable with the outcome, I admit that, I am also willing to still stand that at least it was a patient advocacy perspective, and that man did die according to his own personal belief system. And so that was a win for him and much of a teaching experience for all of us.
And on that note, I would love to hear from some of the imams in the audience. And Chaplain Jones, you had some thoughtful and provocative remarks about, I think, how imams can insert themselves into the care plan of a patient. And you know, what are the, you know, when I try to figure out a care plan from a patient, I have a series of questions in my mind, sort of taking an inventory of to try to get a sense of the patient's values. When you walk in, I would be interested in hearing, you know, how you might approach that in terms of getting at the patient values and then informing the clinical team. How do you talk to Dr. Sahlul or myself and say, hey, let me tell you, I talked with this patient and his family. Let me tell you what they're looking for and when they're not looking for, and let's try to incorporate that into our care plan and see what's clinically possible and what really I think is a goal that we just can't clinically pull off for them, what we can't achieve.
Assalamu alaikum. First, I want to really express my deep gratitude for sharing your experiences. I mean, I'm quite moved by it. I'm a neurologist and psychiatrist, and I particularly appreciate, Sister Najah, how you focused on the emotional processing of dying. And you focused on that, and you kind of shifted the discussion about patient advocacy. And I think it's important that we step back and be clear what are ethical dilemmas versus what are patient advocacy and challenges. So one thing that resonated with me is that you pointed out from the beginning, one of the problems that occurred was the resident didn't communicate effectively with the patient's family by saying this is brain death. It's very confusing. It's saying mixed messages from the beginning. Had the resident said this is your family is dying, it was not an ethical dilemma anymore.
Right.
And so I think it's very important that we're clear what are ethical dilemmas versus what are challenges at the bedside, at the clinical encounter. Likewise with Sheikh Ali, the issue of cremation with the wife wanting to cremate the husband, it's not an ethical dilemma. It's a challenge. You're in a very difficult situation to be in, and I appreciate you sharing that. But for us, in terms of in this kind of the framework of bioethics and whatnot, it's not an ethical dilemma. He has autonomy. He has a right to be buried, to die with dignity the way he wants to die, and it's not an ethical dilemma there. Conversely, if a Muslim wants to be cremated, even you can say it's haram, and you can say we won't be involved in that, but it's not an ethical dilemma. You see, I want to point that out.
For me, I think it is an ethical dilemma because the autonomy of the person was being challenged, but also we're having a conversation which to me was futile in a state that says brain dead is dead. And so if your state law, Islam also has this concept that you must be abided to the law of your land. And so I agree with you, it is an ethical dilemma, and yet it may not be in some respects, but in other respects it is an ethical dilemma. And so the autonomy of that human being, where does it begin and where does it end? And where does patient advocacy begin and where does it end? And where does death begin and where does death end? And so maybe it was very challenging. The good news is so much came out that needed to come out at a patient level, at a hospital level, at a policy level. And here's the other thing, two things so amazing. Could you believe that when we talked about transferring this person to, by the way, a brain dead person transferring to a nursing home, that the insurance company would pay for it? In a state where brain death is death, and then to further convolute this, the other piece of this was that in this particular person's sphere of influence, we had a lineup of imams who were really, really challenging the New Jersey law. And in Orthodox Judaism, the Jewish population has overturned the state law in New Jersey because the Orthodox Jewish belief is that breath and heartbeat constitute life, therefore its cessation is death. And so the state law doesn't apply to them. And so you see how many layers there were to this particular case. Yeah, interesting. Thank you so much for your comment.
Thank you. Thank you so much for today and yesterday. Yesterday, it seemed often we were hearing about the context of the patient, and I think it's fascinating today to hear the context of clinicians and an imam. And I would like you to address further, if you would, how that context provides kind of a compromise between clinical and religious experience in your own lives and interactions with patients and families, because that part of it has been very interesting. Thank you.
There's a physician and scholar of religion and ethics by the name of Dan Sulaiman who wrote really a wonderful book, Proceedings from a meeting he had in Ohio a few years ago. The fact that he held it in Ohio, we won't hold against him. But it was about clinical uncertainty and how clinical uncertainty may reach into what he called existential uncertainty. I recognize that there is an existential uncertainty that I'm part of. That was the concept of ghaib, the unseen, is a very important concept in Islam, and we say as Muslims that part of our iman, our faith, is among the things we believe in is those elements of the unseen. There are clearly elements, and we also know that there is this qada and qadar, fate, and the fact that, and I invoke this every day with my patients, and I say this patient is dying. When is written in a book that I don't get to read until my day comes in that calendar. But I can predict the weather pretty well, and I, at the end of the day, I can say, in fact, what I say exactly is I can act like a weatherman with my Weather Channel maps and my blue lines and red lines and Doppler radar pictures and all that stuff. At the end of the day, you just need to stick your hand out the window and decide whether you need sunglasses or a raincoat. And patients understand that. I don't talk about numbers or prognosis. I say, your body's failing, things are looking really bad, you need to bring your family together. If there's anything you want to do before you die, you have a week, a day, an hour, 10, 9, 8. I mean, it has literally gotten to that point with me in some cases. And I embrace that uncertainty that comes from my faith, that there are certain things that God will just simply never let me know. So I don't use terms that clearly come from my faith, but I use terms that I believe are universal to all of creation, and I share them with my patients. Some patients don't endorse it. I had a patient actually who just died last week whose wife said, we're spiritual people, but we don't do that whole God religion thing. And I say, listen, there's just certain, I sort of changed the terms a little bit. But at the end of the day, it was still, your husband is dying. He doesn't have a lot of time left. You need to set your affairs in order. Whatever those affairs may be. They may be religious. They may be, you've got to tell your family where you buried the money. It could be a bunch of, I don't know what those things are, but I use my clinical expertise, as Dr. Sahlud would say, that's my expertise. We own that. And I think we have to tell patients, I don't know how much time you've got left, but I can tell you pretty certainly, it's not a lot.
The issue?
Yeah. So I would like to answer the question of the sister. Muslims, we have our rules and regulations for burial and all these things. If any rule disagree with the law of the land, we compromise in that. For instance, in Michigan here, you can bury someone without cement on box, they call it, In Islam, we don't believe in that, but according to the law of the state, you have to bury someone in the cemetery, so we compromise in that. In some states, you can bury someone without, like I think in Arizona, they don't put in boxes. You can bury someone without boxes. So that is what we do.
The issue of the death started to be controversial about 40 years ago with the advent of the ventilators and the transplantation. Before that, it was not a problem. And when the Harvard Medical Center made the decision in 1971 that the brain death should be considered as death, and therefore the organs suddenly became available for transplantation, and this is how they started the issue of the brain death as a death. Prior to that, it was a brain cardiorespiratory death. And ever since this has taken place, the Muslim scholars around the world, all the fatwa councils of the world, majority of them given the fatwa, the brain death is death. And however, if you look at this thing, the Imam Ghazali said that when there is living tissue, life, there is life there, and there's a soul there, and it's not death. So I think if you look at this thing, the definition of brain death, that death has been for the need basis, the need or the transplantation of the organs needed. Then the next step came in the cardiac death. That became now is the new reason for the organ harvesting. However, there's a little bit less benefit in that. So the issue is at the present time, the Muslim scholars to get into this thing that define and guide the Muslims, these physicians, as when is the death to be considered as death? What's the definition of death? That's a big controversial issue in medicine. So the death is a physical death, is a philosophical, and where's the religious overlap to that to make the decision, to make the life easy for the Muslim physicians when they are confronted when to pull the plug on that.
I have sort of two.
I'm sorry, one quick thing. If you have a question on either side, if you could line up, that would So really I want to give you a
out.
time update.
Yeah.
We have 10 minutes
Sort of,
total.
I think you're right that the question of brain death did start. It did start with this question, perhaps, of transplantation, and actually, Hasan has written a nice piece on this that hopefully will be coming out in literature shortly. It's water under the bridge, and I mean, here we are with this question of brain death, and I think the origins of it, important as they are, I think we still have to struggle with them. Let's assume, for the sake of argument, that we agree. I'm not sure that we'll get this agreement that cardiac death is death. Well, we have this new device called a ventricular assist device, which is a pump that you can place. And in fact, you may have seen President Cheney, or Vice President Cheney, has pictures of this device. He has no electrical activity in his heart, and he has no pulse. His heart is gone. Is he dead? Without getting into the political aspects of it, some may argue that he never had a heart, but let's put that aside for a second. Looking at the physiologic aspects of this, I probably should not have used our former vice president. But I mean, this is a question that I think experts will have to struggle with, and so we will very soon get to a point where we have a whole slew of patients with cardiac death who are walking around answering questions, but their mudrik, their ability to interpret the environment around them is still intact. And I think there is this question of the relationship of the soul to the physical body that we struggle with, and I think new technologies as they arise will force us. I'm sure that that will not be the last question that comes up in the next 1,000 years that we will have to grapple with.
I want to keep our answers really short so
So-
we can get to all of you, but I have to say something, Dr. Hasan, please. I just want to remind everyone that the Harvard criteria for brain death in 1970 and moving forward was what? Where are the neurologists? 3 EEGs, straight line. I am a testimony, my right hand to God, that 3 EEGs, removal of the ventilator, pronouncement of death on my uncle did not work, and he survived.
Wow.
And lived 6 months later. So this world of uncertainty within certainty is something we better be very careful with.
So before I want to give a time update. So the session was supposed to end at 10:45, which is in 7 minutes. You can go to 10:50, but Professor Ramadan is on his way here. he's taking a flight immediately after he gives his talk. So I would not like to delay him. Thus, we're probably not going to get to all of you. We're going to try as much as we can. But please be very, very, very short, because I want you to get coffee and then come back in. Okay, so 10:50.
Assalamu alaikum. Mustafa Ibrahim, gastroenterologist from Henry Ford Hospital. Thank you for a very enlightening conference. That's long overdue. But the question of euthanasia has not been addressed in this conference, and it should be. It may be, and it's a clear and obvious way. We all know the answer for that, but let me give you one small scenario, and you tell me what you think about that. You get the terminally ill patient, comfort care, cancer patient, that is in a lot of pain, and between the pain medication and quit breathing or leave him in pain. Do you consider that euthanasia if you give him the dosage and that as it should be given, not in overdoses, that jeopardize his or her life? So I think this issue should be, we should not finish this conference without addressing it. It has been an issue around us, and we should have our stand in it and talk about it. So the patient, if you give him him or her the pain medication, will quit breathing within the normal dosage, or you leave them in their pain, and they're alert, Thank you. Assalamu alaikum.
May I respond to that real quickly? In my end-of-life, transition of life experience, I have found something to be very profound. And those of you who do this work, I want you to pay special attention and begin to look at this with a new lens. I believe that pain control is something that Islam is definitely an advocate of. However, it comes down to personal choice as to how much you want be in your wit. And we talked about this yesterday, he and I. But I have learned something clinically. There is a place between pushing Haldol and morphine and the actual death. There is a synapse where not any drug in the world is going to touch that soul. And you can give all the morphine you may want to give within its normal dosage, of course. But that soul seems to still be doing its work until it's ready to depart. And it's been one of the most phenomenal things to watch. And I'll tell you, every time it happens, I say to myself, I know who's in charge.
And I think those of you who are clinicians, I'm sure that I'm sorry, I don't want to take away her applause. I think those of us who are clinicians, I think we've seen that. All of us can relate stories where we've seen, I think, that very special moment that I think increases our iman and, in fact, and increases our faith. As a clinician, I should point out that I really believe pain management is a procedure that requires competencies and skills. And I think if you look at it that way, then I believe it can be done safely. You and I, we routinely do conscious sedation, where we bring people to the point where if we give them a little more drug, they will stop breathing for the purposes of procedures that we routinely do, you in gastroenterology and me in bronchoscopy and pulmonary medicine. I think if we take that model to pain management during the time of death, I think there are procedural skills and goals, and these are well established and published. They're very controversial. There is still some controversy around this, but I do believe that there's some. As for me personally, my personal goals of care is I'm absolutely, actually, this is me personally, I've related this to my family. I'm actually willing to put up with a fair amount of pain so long as I still have my intellect and my tongue intact. Because there are certain things that I want to be able to think and pray and say in my last moments of life. And I've told my family, I'm willing to forego a fair amount of pain medication at the end of life if it means I can still have that intact. And those are my goals of care. And I've related that to the physicians that I want to have take care of. I just turned 40, and so for my 40th birthday, I got myself an internist.
And a will.
Say again?
And a will.
And a will, absolutely.
Thank you so much for sharing your experiences. I know a lot of the discussion yesterday and today has focused on adults. And as a provider primarily of children and adolescents, I've been thinking a lot about consent and assent and capacity to make medical decisions and how that interplays with the Islamic understanding of children and adolescents who are post-puberty and their ability to now be held accountable for their actions and how that interplays with our own state laws and thinking about capacity to make medical decisions and assent. And I didn't know if you could share any of your own personal experiences related to that.
I don't allow my 13-year-old to make any
Oh,
decisions.
good, you're right. Because you are in the medical, in the clinical things. I don't know, maybe Maulana, come and share this and answer with us here. Pardon. Can't give the answer. Come. Yeah, come. 2 minutes, son. 2 minutes, you can't give it in 2 minutes, but come. Yeah. Or Musa, any of you. It's not time.
Well, why don't I intervene here? Okay, so in respect, we can further ask that question to the scholars. It's really a question of Islamic scholarship. However, I will just tell you because I travel the hospitals from the NICU to the ER everywhere. The paradigm, or what I have learned, is that the parent is responsible, has a responsibility to the decision-making for the dependent, but then there is a certain age where the conversation should happen, but ultimately the parents are responsible until the children are emotional, physical, and intellectual maturity. That's the short answer, but obviously that's not, it requires a lot more conversation. We should bring that up at the round table, Sheikh Musa.
That's a good answer.
Just to answer your question, Sada, I did forensic psychiatry. There is a book called Forensic Psychiatry in Islamic Jurisprudence that's translated in English by an author named Qutayba Shalabi. He addresses that point in that book. So, but I don't remember what the answer was.
Assalamu alaikum. Rufaina al-Miski, I'm an emergency room physician at Providence. As Muslims, we're taught not to fear death, not to fear the end of life. And I agree with Sister Najah yesterday. She said we should not address it as end of life. We should address it as transitional care. We need to give our patients dignity. We need to educate our lay community, and maybe this is an opportunity for physicians. We need to work with the imams, maybe to educate and address these issues in the community so patients are informed. We need to allow them to know that there is palliative care. I think sometimes Muslim patients are afraid of the word hospice. The terminology may be worded as such that they are giving up, but I don't know if there is an opportunity for us to work with the physicians, as physicians together, with the imams to maybe provide a need for these patients. There is a need in the community, but I don't know of any Muslim hospice-based programs, maybe word it differently, I don't know, but to serve that same need, to allow to have the patients the dignity. So because I see so many patients become angry when they're addressed with the word hospice. Mm-hmm. So if you can comment on that.
That's very true, Doctor. In the world of hospice, which I'm very well versed in, sat on many of the hospice boards, I tried to spin a Muslim hospice type service. There was pushback from hospice because of the economics of hospice and what they could allow and not allow. And that's a whole other conversation. And so the whole palliative care world is really, I believe, where it's at. I chose palliative care from my father, in fact. And the issue that you hit on that is most important, key, are the words that we're using and the issue of hope. There is no such thing. No physician, no medical person has the right to say there is no hope. That angers families, and it angers Muslims because hope is tied to God. We have the right in our jurisdiction to say there is no medical hope for a cure. There's no medical hope for another treatment, but there is hope for a good transition. And in palliative care, this is how we manage this transition. We can keep your loved one safe. We can keep your loved one comfortable. We can keep your loved one alert. So let's empower this family, let's empower this patient, let's move to this paradigm of compassionate care and not communicate bad news, but really talk about sad news, because what's bad for somebody might not be bad for somebody else. So a lot of it is in the language and how we're communicating. But I agree with you, there needs to be an uplifted dialogue. We need to lift the line of communication, and we can improve patient care, I think, when we do that.
Hello? Yes. I was thinking of the first talk this morning, and there seems to be no X-ray for when the soul's left and when we've died. And the faith in science, I challenge that now. I think here we see it a little bit. And just my specialty is intercultural ethics, and I look at Asian ethics as well as Islamic ethics. And just to put this in relief, again, there's been an ongoing debate in Asia and Japan about brain death. And Japan had the second transplant by Dr. Wada, same time as Christian Barnard, and they ruled against brain death. And been a long time coming. Now it's being accepted in China and Japan. But this same debate has been lively in Asia and East Asia in particular. Moving to Harvard and Harvard Medical Center, Dr. Turog there has been challenging the brain death criteria along the same lines as Sistani. So there's some sense that there's science is on one side and religion is on the other side here. I think there's the sweet mysteries of life in the Supreme Court on abortion. It's like when life begins and when death occurs. There's debate on both. And so my question is, Turog has suggested that we should move away from the definition of death and move to the question of what is obligatory care and obligatory life support. And that, I think, is a really fruitful way of thinking about this. To Professor Brock's talk yesterday, public reason doesn't tell us when death happens. Respect for each other is respect for pluralistic conceptions of death, perhaps. But it is a public decision of whether we maintain people on life support, spending enormous resources when their brain is dead and there's no hope for meaningful recovery. So my suggestion and question is, what do you think of moving to a debate on what is obligatory care from what is death? Thank you.
I think that's very smart, very wise. And by the way, we haven't even talked about PBS. We haven't talked about persistent vegetative state yet. So